Okay, so, I'm gonna pull this over here and try to stay with the, PowerPoints as best I can, okay? So you all kind of help me, keep me where we're supposed to be with the PowerPoints, okay? So, because I know, like, I'm one that I like to follow things exactly the way that it is, and I know some of you all like to do that as well. So I don't like to hop around. It gets me confused and gets me off, and so I'll try my best to stay along with the PowerPoints if you all can help me to stay with them. All right?
You got GERD first, so that ends.
Oh, I do?
It's
Okay.
GERD and then it's gastro. Whatever you wanna do.
Okay, well then let's do GERD. Oh, well, you get your pen. I don't want to steal your pen. All right. I forgot that I said I was gonna do GERD. Okay, so they're videoing this, so if anybody wants to view the videos, we will have, I'll put those up on iTunes.
Oh my,
Or
where's
not
the
iTunes,
camera at?
but I'll put a link. You all can't see, can you? I had you on. All right. So let's talk about, gonna talk about GERD and hiatal hernia together. Because usually if somebody has a hiatal hernia, they're gonna have GERD, or if they have GERD, they're gonna have a hiatal hernia, okay? So what I wanna discuss is the manifestations, first of all, that we're gonna see. And what are we going to do as far as being the nurse, and what are we gonna assess? So patient comes in, they just say, oh my gosh, I have got terrible heartburn. I feel like I'm refluxing everything back up that I am eating. This can be anywhere from a day or two to, up to several weeks, months. People just do not get it checked out. Now, we need to encourage our patients, if they're having lots of reflux, they might come in for something else, but then they find out that they have reflux, or that, through questioning and assessment and those kinds of things, maybe they just have some dysphagia, some nausea, those kinds of things. But when we're investigating, we need to go ahead and further investigate what upsets their stomach, okay? So they've got heartburn. So when was the onset? And when does it happen? Like after meals, at night, like at bedtime, and what do they eat? So what foods causes it? Foods. So what foods do you all think might cause regurgitation or
Spicy.
what?
Spicy.
So some spicy foods. So spicy. What else? Acidic. Okay. Do y'all know what's in this right here? Take it, vodka. No, it is not. No. Good try. So what do you all suspect is in this?
Coffee. You say
So
coffee
some
drinker.
coffee. So what is coffee? What does it have in it? Caffeine. So what is caffeine? So stimulants, all right? So caffeine or stimulants. So when we're talking about, when we're trying to devise through our assessment, and we're trying to gather information through our assessment, those are some of the questions that we want to start out asking, okay? Now, can we do a physical assessment on the esophagus? It's not a trick question, really.
I mean, you can't really look.
So you
down
really
there.
can't look at it, so you have to go a lot off of what the patient tells you when you're trying to determine what's going on with them. Now, we can listen to their abdomen, we can look at their abdomen, We can get bowel sounds. We can look in their mouth and see if there's any kind of breakdown in their mouth. But most of the time, they're gonna come in and they're gonna say, I've got terrible heartburn, I've been taking Tums, I've been taking Pepto-Bismol, I've been taking, all kinds of things. My mom swears by papaya enzymes and they do help. I've been taking all of these things and, I've still just got heartburn terrible. And it happens every night when I go to bed. So long term, and then because of the changes that can happen in that esophageal area from long-term dysphagia, long-term regurg, long-term, issues there with heartburn, it can cause scarring. So over periods of time, if GERD and reflux are not treated, that can lead to what's called Barrett's esophagus. And Barrett's esophagus is the changes in the lining of the esophagus, okay? Those changes in the lining predispose patients to esophageal cancer. So if someone has Barrett's esophagus, then they need to have diagnostic EGDs every so often to determine if those changes, because they're going to need to biopsy that and make sure that it has not turned into cancer. Because Barrett's esophagus, that tissue is precancerous tissue. Usually we've got like the epithelials in the esophagus, they change and the tissue looks completely different once Barrett's esophagus they've been diagnosed with that, okay? So they may feel full, they may even have chest pain, okay? So it may be chest pain, and it may radiate because this can mimic heart disease, okay? Some of the signs and symptoms that we see. So we have to rule out, we may start with a cardiac workup, and ruling out cardiac disease will bring us to the point that we have, something going on in that gastric area, in that upper gastric area, okay? So usually what we do is, they go in, they have a treadmill, they have all of those things, everything comes back normal, so then we say, well, you're gonna have to have an EGD, all right? Because they can't have, you don't wanna put a patient to sleep that might have cardiac issues for an EGD. So if they're coming in and they're presenting with chest pain and, all of those signs and symptoms that go along with a cardiac event, then anesthesia is not gonna put them to sleep until they've had cardiac clearance. So before they can do all of this, they're gonna have to have all of the cardiac stuff done, okay? So diagnostic EGD, that is the gold standard. That is the most definitive way to determine if they have GERD or a hiatal hernia or both. Like I said, most of the time they have both. So remember what I said about EGDs. What is your role as the nurse? Patient comes in, they're having, all of these symptoms. Well, we're gonna work you up with an EGD. So what do you have to do for the patient?
I think NPO's so long before.
So NPO at least 8 to 12 hours before. And is there a prep? Do they need to have a prep for an EGD? Do they take
That way, no.
right, for the upper scope, there is no prep required. They just have to be NPO. Now, some other things that you need to be cognizant of are the medications that the patient may be taking. So if they're taking aspirin or Plavix or Brilinta, then that physician that has ordered that needs to be consulted because they need to be the ones to determine how long that the patient is off of that medication. As the nurse, unless you have standing orders that says this is how long the patient needs to be off of this medication, then you have to consult with the primary care doctor, okay? So they may say, the patient needs to be off of their Brilinta for 5 days. The patient needs to be off of their Brilinta for 7 days. And if that doctor, if that's his routine, then you can go ahead and tell the patient that, okay? Unless it's contraindicated. Now, you might have to check with the cardiologist or something. Diabetic medications, whatever that the order says. If it says for them to be off of it, take a half a dose if it's an insulin shot, if it's some kind of insulin, then they might say, well, decrease your dose to half for the day before and the morning of, and then you can resume your normal. So whatever that the medication orders are, that's what you need to do. Other things, the intraoperative or preoperative, you're going to have your IV, just like what we talked about, an IV for an EGD. You're going to have to either do something to numb up the back of their throat. And then post-procedure, we're going to monitor them for gag reflex, prevent aspiration, keep them on their side until they're awake, and then don't let them have anything to drink or eat until the gag reflexes return. And that's usually, it starts returning within 30 minutes to an hour after the procedure, okay? All right, we can also do a barium swallow and a CT, and just remember on those barium swallows, afterwards, they got to increase their liquids, and they may need to have a stool softener or a laxative to get all of that barium out. And you've got to monitor or teach them how to monitor their stool to make sure that they've cleared, okay? So that you want their stool to go from chalky back to brown, all right? CTs, remember, if the patient's having a diagnostics workup, they may have a CT of the chest because they may want to rule out any kind of tumors or anything like that, so they may have a CT. So remember your important things about a CT, and those are what? Couple of things. One big thing you got to check.
Yeah.
Allergies and what else? What? Who said it? Kidney function. BUN and creatinine on a CT. All right. If they already have some kidney dysfunction, then we need to check with the provider because they might get, what's that medicine that I said? Nope. If they've got kidney dysfunction, they're
you'd give that
getting
Mucomist.
which is the N-acetylcholine.
Big word.
Yeah, that. So they're getting, so Mucomist,
Luke's taught us.
and they're also going to get, they're gonna have fluid resuscitation afterwards, so they're gonna, flush out their kidneys, all right? And they might get some bicarb. So normally, this can be managed okay. Usually patients can manage with modifications, within their everyday limit. So smaller, more frequent meals, so usually about 6 meals a day. Small portion sizes. We want to encourage them to sit up after they eat for about an hour. So, you eat all these big meals, and then we want to go and lay down. But these folks need to sit up, all right? Also, just like your posture. Remember the other day we were talking about, the older population and how that they're all bent over. So, if you can kind of straighten up, that helps to straighten up that esophagus and, all of that gastric area, and can help with empty, okay? If they have it severe enough, they can put their bed up on blocks, elevate the head 4 to 8 inches, and so when they're lying down, they're not supine, they're supine, but the head of their bed is elevated, just be like they was in the hospital, and you've got them in reverse Trendelenburg, reverse Trendelenburg. So, elevating that head of the bed. Avoid stimulants. So those coffee, chocolate, carbonated sodas with caffeine in them, those can cause reflux. Even the carbonation can cause some reflux. Okay, so we want to avoid those. So coffee, they've told me to stay off my coffee. You can see I do not listen well. I don't eat as much chocolate, but I have like lately been wanting chocolate a lot. So, any stimulants. So, low fat diet. Why would we want to encourage these folks to be on a low fat diet? What would be helpful about that? Think about your stomach emptying, okay? So when we think about the foods that we eat and our gastric empty.
We maybe have a hard time breaking it down.
Okay, so fats, what empties out of the stomach faster? Fats, carbs, proteins. What's gonna be your fastest empty? Think about when you eat carbs and fats, what does it do to you? Slows everything down, right? If you eat a high carb or high fat meal, you get real sleepy, you get like stasis, you just want to just be so sluggish. All of those things slow you down, make you sluggish. So what's it gonna do to your gastric emptying? It's harder to break down, those things are harder to digest, they don't empty out as fast, so you've got everything sitting in there. So you have a better chance of refluxing it back up. So you want to encourage lower fat foods, okay, so that you have faster gastric emptying times. All right. So you gotta know why you're telling your patients to do these things. You know, that's important to understand the why behind what we're doing. And then avoid eating 2 hours before bed. That's the same way with sitting up, because once we go to sleep, everything slows down. So if we're slowing down and we're going to sleep with a full stomach, what can happen? You got reflux, you can aspirate. So if you tell them, you have a chance of getting aspiration pneumonia, you could die in your sleep because you could aspirate and get choked, and nobody may not hear you. Like me, you just die when you go to sleep. I'm sure y'all do the same thing from exhaustion. So, that is one thing that's really important, is making sure that they understand, because we want that gastric area to be empty before they go to bed. Right? Avoid tight-fitting clothing. Why do we want to avoid tight-fitting clothing? Okay, I'm going to show you. I've got my blue jeans on that is so, I cannot stand tight fitting clothing. I'm just gonna tell y'all. I'll buy them a size too big and put a pin in them or something. I cannot stand tight fitting clothing. But you got on a pair of jeans like this. It's right around your waist, and what's it doing? It's putting pressure, it's constricting, so it's harder for everything to move out of that gut. Okay, so you want to avoid tight-fitting clothing. A tight belt, you don't even want them to cinch that belt down, because that belt, I always think about the guy on the Duluth Trading Company. He puts those tight clothes on, and it just like squeezes everything out. Take medications as ordered, and your book has a list of medications on page 1284, and it breaks it down into the different medications. So there's antacids, which includes Tums or Maalox, H2 inhibitors, which are famotidine, ranitidine, and cimetidine, and it tells you the nursing considerations and why that we are giving these to the patient. So you can give some of these by IV. Sometimes we put patients on these as preventatives for surgery, but these folks are on these so that they do not have the acid production. And then, or to prevent ulcers. So then there's your PPIs. So those are your pantoprazolol, omeprazolol, lansoprazole. You can see all of the alls are the PPIs. Reflux inhibitors, and then surface antigens, and which is Circulafate, which is Carafate. Okay, and it does not Carafate does not prevent ulcers, it just helps to coat the ulcers, okay? It's just a coating. You all can look over that, take note of like when you would give some of those medications. Some of those are like nursing considerations. Like the PPIs, it says it increases hip fractures and it can interfere with vitamin absorption, like vitamin B12. So people who are on PPIs, they may not absorb, they may not be making an intrinsic factor the way that they should, and they can't absorb B12. So that would be something important to note, okay? And when do you give them and those kinds of things. So just kind of look over that box and know the classification, and you know, you can usually tell the class on the generic because the end thing. In extreme cases, if it's really disrupting someone's life, they can have surgical intervention, which is called a Nissen fundoplication. So they just go in there and they take apart the stomach and they pull it down and they wrap the esophagus around, and these folks, it's a life-altering surgery and it cannot be changed, okay? So they have, you know, they have some long-term lifestyle modifications. We had a patient yesterday at the hospital that had a Nissen. So they, you know, they had to have teaching on, you know, things to eat, how they have to eat a lot slower, less, you know, less volume, okay? Questions about hiatal hernia and GERD? Anything? All right. So we're going to gastritis next. Is that right? That's the next chapter. Maybe I won't pinch I'll pinch my fingers in this little thing on the way down the elevator. All right. So inflammation of the gastric or the stomach mucosa. So we've got inflammation there. That can be due to infection. It can be due to anything that has caused a disruption in the gastric mucosa. So what do we see with these folks? One of the big things is hiccups. We may see hiccups or nausea and vomiting. The patient comes in and they just have frequent hiccuping, and so it can be attributed to gastritis maybe. Now chronic, and you all will notice on a lot of these upper disorders, you're gonna see a whole lot of the same things. So this one, we've got heartburn. That one, we had heartburn. A sour taste in the mouth, you can see that with hiatal hernia and GERD because the reflux of things back up. So if you get gastritis, there's a chance they're gonna be refluxing things back up, okay? Epigastric dysfunction. So vitamin deficiency. Why are they gonna have vitamin deficiency? Why can you see can you all see that? Y'all wrote that, didn't you?
No, I didn't.
Okay.
I did.
Okay, so why will you see vitamin deficiencies?
The lining's messed up because it's inflamed, it can't absorb it.
Okay, if the lining in the gastric mucosa, so where do we make intrinsic factor?
In your stomach.
So in the stomach, and if we can't make that, then we can't absorb B12, okay? So we may see some vitamin deficiencies. And then we can see belching with it as well. So they have really outlined well some of the signs and symptoms. So when the patient comes in, you know, is there anything definitive right here that would lead you to believe that the patient has gastritis over having a hiatal hernia or GERD? Is there anything? So the hiccups, but they don't all always have hiccups, okay? So they may just come in and say, oh, I'm having abdominal pain, nausea, I vomited a few times, you know, I'm having heartburn. So you don't always see hiccups with it, all right? So how are we gonna determine that the patient has gastritis and doesn't have GERD or hiatal hernia, and they may have GERD and a hiatal hernia with the gastritis?
Well, that's gonna be more in your stomach, lower, or you know, in your stomach area versus up in your esophagus.
Right, but you get a lot of the same presenting signs and symptoms there, okay? So how are you going to determine?
Obviously you can't.
What's your diagnostics? Okay, exactly. EGD. That's the way. So they listed over here your assessment, and they've got endoscopy. I didn't see that, sorry. And a biopsy. All right. So they come in, abdominal pain, and with the abdominal pain, they're complaining, you know, that it may be a gnawing type pain, it may be a burning type pain, there may be varying degrees of pain that the patient is having. So this can be associated with not enough hydrochloric acid, none, not enough, hypo, or too much, hyper, okay? So there are varying degrees there. I don't really care that you know what the degrees are other than to know that A is none, hypo is low, hyper is too much. Because diagnostic studies are gonna tell you what that diagnosis is, if it's not enough or too much, okay? So we have to go in with an EGD. So the patient's gonna go in with an EGD. So you see again, you've gotta do that same teaching, right? But what are gonna be my nursing interventions? These are real important with this disorder, okay? Because with gastritis, you've got to decrease that inflammation, because if you don't, what can that lead to? What can we see? Deterioration. Yeah, I mean, if you keep that, it's like with anything, if you leave the inflammation there for long enough, it's gonna cause long-term problems. So you could get bleeding, you could get perforation, you could get ulcers develop, you could get a great number of things that would be going on. So the patient goes in, they have their EGD to get a definitive diagnosis, and it's diagnosed that yes, they do have gastritis. So we're gonna have to do some nursing interventions. So we see this again, right? We see decrease those stimuli, the things that are stimulating. Because, when we put in a stimulus, how many of y'all drink coffee or Coke? And you've gotta have your caffeine first thing in the morning because it stimulates us, it gets us going. So that gastric mucosa is already inflamed, it's already going, and then you put another stimulant in there. Smoking is the same way. And then smoking also destroys that normal tissue, all right? So we need to encourage lifestyle modifications. So when I say lifestyle modifications, that can include anything from smoking, alcohol, foods that they eat, those kinds of things, all right? Monitor eyes and nose, because if they have gastritis, do you think it's gonna be real comfortable for them to eat? No, it's not. So they may not be taking in the nutrition that they need. So if someone has severe gastritis, where they can't eat or drink, then we may have to do supplemental something for them. They may have to be on liquids, they may need to be on protein shakes, if it's something really severe, which I can't imagine that, it would, but they could need a feeding tube. There are situations that they could need a feeding tube. Now, could they put a feeding tube in the gastric mucosa if they've got gastritis? No, you need to avoid that area, so it would need to go further down into the jejunal, okay? Teaching them to reduce anxiety. What's anxiety gonna do for gastritis?
Make it worse.
Okay, it's gonna make it worse because what are we doing? We're secreting more acid in the stomach. And we've already established that the stomach pH is like 1, so it's very acidic, and then we're anxious. You all probably have like all kinds of stomach acid secreted, like the closer that it gets to an exam, right? Y'all just get all that, or a check off or something like that. So you get all this extra stomach acid that is secreted. So we want to use meds appropriately. So there again, these same meds are listed, that's listed in your book. So for gastritis, we want to decrease the amount of acid that is secreted. We may need to coat that stomach, so they may need some Carafate or some sucralate, golly,
I can't pronounce
I
any
hate
of them.
generic names.
I can't do any of them.
They may need a PPI, and if it's severe enough, we've had patients in the hospital for gastritis because it's severe enough. They've got nausea, vomiting, so their hydration status is poor, their fluid status is poor, so we've got to do fluid resuscitation. And when I say fluid resuscitation, that doesn't mean that we're giving them boluses of fluid, but we're trying to correct their hydration status, okay? Pain level. Are these folks gonna have pain?
Mhm.
Yeah, anybody have belly pain? It can be severe, and especially with gastritis, you can have some severe discomfort in that area, and it's just like, oh my gosh, you don't get any relief, okay? And it can be to the point that, they could be vomiting up some blood. So you really wanna monitor that. Monitor the stools for frank blood or occult blood. So do you think it's gonna be frank or occult?
For stool? Oh, that's gonna be.
The stools.
Okay, occult, because it's higher up.
Okay,
Be
so
that-
it's gonna be higher up, so
Dermatory stools.
most likely, now, you could see some frank red blood. You really could, if you've got an active bleed, and they may have diarrhea and everything is emptying
Okay.
out, really quickly, depending on any other disease processes. So, you can see a spectrum of things. Most generally, you're gonna see dark tarry stools, okay? So occult blood, it may just be hidden blood, it may not be a whole lot of bleeding, the stools may not change a lot, but if we don't see it in the stools, where else can we note that there's something going on?
You mean in their vomiting?
Okay, in their vomiting, but where else?
Oh, their labs. You're talking about
Their labs. So we wanna look at, and they said their electrolytes, but we also wanna look at their H and H. So electrolytes, if they are vomiting, their electrolytes may be off. So their potassium may be low, their sodium may be low, everything may be low. So, we have to keep a check on that. Patient teaching, why do we wanna avoid NSAIDs? They wrote NSAIDs.
They're the number one cause of ulcers.
They're the number one cause of gastric problems, gastric ulcers, gastritis. They are very irritating to the gastric mucosa. So people who maybe have oral problems and they're having pain in their mouth, they may take a lot of NSAIDs, which then, they're having problems already with their mouth and they're not eating as well and they're taking NSAIDs and they're probably just eating whatever. So then they can get into having gastritis, okay? So real important to kind of make that connection there. But NSAID, alcohol, what does alcohol do? Is alcohol a stimulant? Yes, it's a stimulant. So it can we can see gastritis in people who abuse alcohol. We can really see it there. Modify the diet. So they may need to refrain from hot, spicy foods and foods that are a little bit easier to digest. Okay. If it is acute, then they do need to refrain from alcohol until it subsides, and then they only need to use alcohol in moderation. So moderate alcohol use, refraining from smoking, dietary modifications, and monitoring for any signs and symptoms of, complications, which would be, a perforation or bleeding. If they're bleeding and they have an active bleed, then they're gonna have to go to endoscopy, all right? Any questions about that? Did I cover everything? Did we get everything? All right. Everybody feel okay about that one? How to take care of your patient if they roll up in there with a gastritis. You gotta gotta try to figure it out, but it's usually, you gotta go for an EGD to figure out what's going on. Okay. Peptic ulcer, is that next?
Yep.
Okay. So, peptic ulcer disease. Now, where do peptic ulcers occur? Do I need to move this over a little bit?
A little bit, yeah. Oh, yeah, oh, she's got it.
Where do peptic ulcers occur? Where can they occur?
Your stomach?
Stomach, the duodenum. So we're thinking gastric, peptic area, that's the stomach area. So they can occur in several different places, okay? So when we look at the manifestations, all right? So let's look at causes first. So aspirin, NSAIDs. NSAIDs are bad, but they're good.
Mhm.
They work so good, but they're bad. We can have a genetic predisposition, but this right here, this little culprit right here, the H. pylori, that is a mean little dude, and he is usually what could cause peptic ulcer disorders. We see that with more peptic ulcers than not, okay? That's one of the number one causes of peptic ulcers. So we can have ulcers in different areas. Now, the presenting signs and symptoms are going to be a little bit different based on the area that the ulcer is in. Okay, so depending on where the ulcer is, you might see different signs and symptoms. It's the same signs and symptoms, it's just when they present. Okay, so sudden onset. We can definitely see sudden onset with sharp upper pain that was referred to the shoulder. So now, this can be with eating or it can occur after eating. So I want you to think about this. If someone has a peptic ulcer in the gastric mucosa, in the stomach, in the lining of the stomach, so do you think that they would have pain when they eat or a little while after they eat?
I think a little while after.
Because you all got gnawing, burning pain.
Yeah.
Okay.
It had different types of pain. That's why I listed all three.
Okay, and that's good. That's good. But this is that right here. This is the point that I want to make. Because if a patient comes in and tells you, I start having pain right after I eat, and they've got peptic ulcer disease, what are you thinking? What do you need to think? Is that ulcer in the stomach or is it in the duodenum?
My stomach.
So it's probably in the stomach. Now, if they start having gnawing type pain a couple of hours after they eat, let's think about it. Your stomach is starting to empty out into the duodenum. So after your stomach empties out, then all of that is the food is starting to go through that area. You've got an ulcer there, so it's starting to get irritated, okay? So your food's sitting there and it's digesting, and then it's starting to, go out from the stomach and into the duodenum and the small intestines. So it's irritating the stomach, or irritating that duodenal area, so then that's when you're gonna start seeing the pain. I don't have pain, I can eat anything, and then a couple of hours after I eat, my pain starts. Well, that's because the area is not being irritated until after the food starts emptying. Okay, so does that make sense? Does that help? All right, so we can see burning type pain. No, so you've got an area in that stomach. So your stomach is here, and you've got an ulcerated area there, and you're putting food in it, and that's just like an open ulcer on the skin. Think about the open area on your skin. You've got an open area right here, and you're putting food in there and stomach acid, because once you eat, your stomach starts to produce acid, so then it's going to be irritated. All right, so that's where you're going to see your pain. If it's an ulcerated area, what do ulcers do on our skin? They can bleed. So we can see hematoemesis. Okay, so blood in the emesis. We can see melena, which is blood in the stools, okay, because it's gone through the digestive process. All right, so the nurse needs to be assessing these things. asking, have you noticed any vomiting of blood? Have you noticed any changes in the color of your stool? You know, blood can be, if you know, have blood in there, it just is a terrible feeling and taste and everything. So just kind of a metal taste. So, you know, a lot of times patients will vomit that back up. On the physical assessment, you wrote distended, tender abdomen, and that is the truth. Because if you've got an ulcer, you know, everything is probably not going to empty the way that it should. So the abdomen may be distended. You do some palpation after you listen, and then, you know, they're complaining of pain and tenderness in the area, okay? And it's probably going to be that upper gastric area, but it could be some referred pain. You know, you push on their belly, pain, you know, they may have shoulder pain. They may have right shoulder pain, all right? So if they're having right shoulder pain, your duodenum is right here, generally, right in here, and then that pain just kind of refers up, okay? That old upper endoscopy is showing up again right there, okay? So we see that again. CBC, what are we gonna see there?
And the H&H.
So H&H.
Go down.
And I think we wrote H&H over here. So we got to check our diagnostic values. That's part of your assessment. You know, we think our assessment is going in and assessing our patient and looking at our patient, but we got to put all the pieces of the puzzle together. And the diagnostic evaluation is part of that assessment, because you've got to look at it and report your findings here, correlate with what your physical assessment findings are. And if they don't, then you might have to go back to the drawing board and collaborate with the doctor, okay? And hemocall. So how many times are we gonna do a hemocall? Usually 3 times, okay? Y'all listened really good whenever I was talking about modalities, didn't you? Antibiotics. So what antibiotics can we give? Your book has a list of all of the medications, and I want you all to look at that table in your book. I don't know what page it's on.
$12.95.
$12.95. Oh, I flipped right to it. So $12.95. So what are some of the antibiotics that we can give?
Amoxicillin.
So amoxicillin. What else?
Clarithromycin.
Okay. So which is Biaxin,
Okay.
erythromycin.
Tetracycline.
Okay.
And I don't know how to say the other one.
All right. Flagyl, or it's metronidazole. Okay. Metronidazole. Y'all got to know those generic names.
I know.
So, okay. MET, was it MET?
RON.
RON.
IDA.
IDA.
ZOLE.
ZOLE. Okay, so what do you need to teach your patient on amoxicillin?
Take all of it.
Amen.
Take all of it. If you're allergic to penicillin,
You can't have it.
take all. PCN allergy. So you gotta check that. Check a penicillin allergy. What about flagyl? What do you need to tell your patient about flagyl? Or clarithromycin? Either one of those.
Humidin.
Okay, avoid alcohol. They can cause GI upset. So if they cause GI upset, well, that's this one and this one. So GI upset. So what do you want to teach them? If they're taking one of those medications, what do you want to teach them? Take it with food. Okay, so take with food. Because if they don't, it's just gonna give them the upset. And they need these medicines. Because if it is from H. pylori, and remember we already talked about how to check for H. pylori through the EGD, but if they have H. pylori, they've got to eradicate that, and they have to have antibiotics, okay? We usually give, Flagyl is one of the bigger things that we give for H. pylori. But in addition to the antibiotics, they need to be on a PPI or an H2 antagonist because they want to decrease the acid production. So, and then bismuth salts, that's just like Pepto-Bismol. That's what that is. Okay, so something like that. But these all need to be, they can do a combination of 2 of these, or they can do all 3 of these. Okay, and depending on what they find, depends on this. But just know what your nursing interventions are for those classifications of medications. Okay, you always want to check for an allergy. But you know, with any of them, if it says give it with food, you want to give it with food because you don't want that
Make it
GI
worse.
upset. Y'all done a real good job of your interventions and your teaching here. You want to reduce pain relief, and this right here will help to reduce the pain. But you want to avoid NSAIDs because, you know, that's not going to help the
Make it
GI
worse.
system. Include the family with teaching. Keep the optimal nutritional status. So, you know, encourage foods that are easier digestible, that are going to be easier on the stomach. Okay, it's at least until the gastritis clears. Now, they might have to come back and have another scope done just to see if that gastritis is cleared up. Okay, and then complications, all of those complications, hemorrhage. Hopefully, we're not going to get to that point. Let's see. Oh, temperature of the foods. That's a good one. Really good. Because you don't want them to eat a lot of hot foods. That's just going to make the GI system worse. And then 3 meals a day. And we always, smoking cessation is just
Everything.
always, it's just everything. It's just one of those. You just want to always cover it. All right. What did we miss? Did we miss anything? You all going along on your slides? Anxiety, you do want to decrease their anxiety. And on your slides, I think I've like really laid it out there with most everything, you know, on your slides. There's a lot of information on the slides, and you all can follow along in your book with the nursing planning and interventions. Okay. I am not going to talk about constipation or diarrhea. I should not have to talk about that. You all can read that in your book, okay? Because we're going to move on to chapter 47. Is that right?
47.
Is it 47? Is that the next thing? Y'all keep me on track.
Irritable bowel, yeah.
All right, so irritable bowel. So constipation, diarrhea, you all can read over that. It should take you about 10 minutes to read over constipation and diarrhea. And it talks about laxatives
Where should I
and
put this?
those kinds of
Over
things.
here?
And I'll probably refer you back to some of those. So IBS, where did that?
Right
leave?
behind you.
Oh, yay. Okay. How are we on time? We okay? Oh, 15 minutes, mercy. Well, I'm not gonna like blow through these, okay? Even if I have to do this after class and record it after class so that I can upload it and you all can have it, I will do that. All right, so IBS, so irritable bowel syndrome. We want to, this can be a very embarrassing, we're moving to the lower GI system, okay? So everything now is lower. So it can be a very embarrassing situation, very embarrassing thing for patients. So, you know, it may take them a little while to come in. They may have been having problems for a very long time. You know, they may have been having problems for months, for years. So they come in and they're complaining about different levels of bowel dysfunction. So there can be irritable bowel with constipation, irritable bowel with diarrhea. It can be a combination of both. It can be mixed. And, you know, so we've got to kind of determine what is going on with the patient. So you all listed that up there. The patients will oftentimes complain of pain and bloating with eating. They may have a sudden urge for defecation, and they may not absorb nutrients the way that they should because they're having to run to the bathroom really quickly, okay? It often can occur with GERD, so we can see it patients who have reflux disorder, they may have, there may be a correlation between that. Fatigue and fibromyalgia, there's a correlation between that, and people who have depression. So when you're doing your assessment, you want to find out about any disorders that, this marker's not right very good. You want to find out about any disorders that the patient might have, any other disease processes that they may have that may contribute to IBS, okay? We've all seen those commercials, I'm sure, about the, about having to find a bathroom really quickly and, they're advertising their medications. So, when we do our assessment, we want to ask them, is it precipitating with meals? Do you have to, can you not go out to eat? Can you, do you have to go, about how long after you, or, are you constipated and are you having stool, less frequently? So, there's varying degrees, so you just want, when we talked about that health assessment, the first day, we want to find out what the patient is, what their bowel habit is, what their normal is, and is this normal for them? Going, not going. And they may alternate between, they may have constipation for 3 or 4 days, and then they'll have diarrhea for, 3 or 4 days, okay? So interventions. We want to, well, let's look at labs first. So we can get a CBC, see if there's any kind of bleeding disorder going on, any bleeding. We need to do fecal studies, stool studies, and get a stool diary. So, and then we can do celiac testing to see if they have celiac disease, all right? So these are some of the diseases, some of the things that we can do. Colonoscopy, that's just like the EGD. Colonoscopy is going to give you a definitive visualization of the colon. And remember, we talked about all of those things that you got to make sure that they take their prep, that they're clear. That's one of the biggest things, making sure that they're clear. And then a stool diary. How is a stool diary going to help?
Well, it tells how often
Their
they're going or
pattern.
not.
It gets a pattern. You establish a pattern. Okay. So interventions, you want to relieve abdominal pain, and we can do that by several ways. Increasing the fiber in the diet is going to help them to evacuate the colon a little bit more routinely with bulking up. That will help to prevent constipation and diarrhea because you're bulking the colon up. Increasing fluids. Okay, so they wrote increasing fluids there. Do we want to increase the fiber really, really quickly with someone? Do we want to say, you start taking 25 grams of fiber a day? No. We want to slowly increase that fiber up and increase the fluids because we have to have fluid to pull into that large bowel and get that large bowel hydrated, okay, to make the stool pass a whole lot easier. Let's see. Restrict and gradually reintroduce foods that are possibly irritating, which that's a really good intervention because we might need to eliminate everything and start all over and see what is happening with the patient. So we need to get a food diary. So that's another thing. Food diary. What are they eating? Ask them what they're eating. What's causing the irritation. And then meds. So we can give them loperamide, which is an anti-diarrhea. We can give them Lotranex, which is an a selective, what's that say, 5-HT3 antagonist. So there's several medicines that you can give these folks, but we usually antispasmodics and anti-diarrheas for those folks, okay? And then teaching, stool diary, avoiding the irritants. I mean, IBS can be life-changing. These people, you know, they suffer a lot of feelings of isolation because maybe they can't go out, maybe they feel like they can't go out. So, you know, they suffer a whole lot of isolation. Good sleep patterns, good dietary habits, because that's gonna help to establish normal bowel patterns. They may need to have some cognitive teaching to like adjust their cognitive behavior to think about using the bathroom if they have constipation. You know, so they may need that. Stress we've got it here again, avoid alcohol and cigarettes. Stress management can stress, because we get stressed and what happens? Everything we start releasing all those endorphins and all that norepinephrine, and then we get all in a tizzy, and when we get in a tizzy, what happens? We get diarrhea, right? Y'all get nervous diarrhea before
Absolutely.
test.
Absolutely.
So, you know, this can be a really life-altering type of disease process. So we've got to get to the bottom of what's causing it. Is there an underlying, do we have an underlying cause here? Okay. Is there, you know, some kind of microorganism that they're growing in their colon that is causing this? Or is it just their daily life? Is it just life that's causing that? Okay. All right. Any questions about IBS? Hey, what's the next one?
Yeah, appendicitis.
Appendicitis. All right. Oh, I bet the wheels are locked. Whoop.
I'm gonna flip that one out.
Maybe I won't. Okay. Appendicitis. So we all know where our appendix is located. So when the patient comes in, they're going to present with possibly vague periumbilical pain. So even though the appendix is kind of on that right lower quadrant, it might be that they're having pain around the umbilical area, okay? So it usually is accompanied with nausea, sometimes vomiting, and if they have appendicitis, they probably are going to have a fever, okay? So we're going to see a low-grade fever. Localized tenderness. So where is the localized tenderness? What's that place called? On McBurney's Point, thank you. So McBurney's Point, we may have some localized tenderness. As the nurse, do you need to do deep palpation at McBurney's Point? No, you can palpate that area. See if there's any pain, any tenderness there. You want to palpate. So right along in here, where that ileocecal valve is, the appendix is coming off of that. So at the end of that appendix, you might find some tenderness there. So that's McBurney's Point, okay? So we're going to check there. So we're looking at the abdomen, seeing if there's any distension, see if there's bowel sounds, because if the appendix ruptures, what can we see? Peritonitis. Okay, so we can see peritonitis. So we want to do a real good abdominal assessment. Listen to the bowel sounds. Check the vital signs, because what are we going to see if there's peritonitis? And I know I'm getting ahead of myself because peritonitis is one of them, but I probably need to have peritonitis turned around here and talk about both of them at the same time. So we can see that an increase in what? If they start getting a systemic infection, increase in white blood cells, increase in fever, but what would clue you in subtle changes other than fever? Heart rate, goes what? Up or down? Heart rate goes up, blood pressure goes down, you get hypotension, okay? So tachycardia, hypotension, if you've got peritonitis, and with appendicitis, you can see that if the appendix ruptures. Same thing with the diverticulum, if it ruptures. You can get infection going out into the peritoneal cavity, which can get systemic, and they can get septic, okay? So, your nursing assessment, a complete history. When did the pain start? What is the pain intensity? What is the pain location? And then, like I said, your physical exam, which is going to be that abdominal GI assessment, okay? Are they nauseated, vomiting? So what's the definitive diagnosis, other than the physical checking the McBurney's point and looking at the labs with the white count and all of that? How are they going to decide if it's the appendix or not? CT. So they're going to do a CT. We're going to get a white count. You can get a C-reactive protein, and that'll be elevated, but CT. I like that you ruled out pregnancy and you wrote transvaginal ultrasound here and a urinalysis, because somebody could have an ectopic pregnancy that is mimicking the same signs and symptoms of appendicitis. So you definitely want to rule out pregnancy. Okay, so, and on a CAT scan, you know, you've got to do a pregnancy test on somebody that's of childbearing age before you do, you know, you do any x-rays. So you do a pregnancy test, and then possibly, if they were pregnant, a transvaginal ultrasound to make sure that it's not ectopic. And then you can do a CAT scan. So all of those CAT scan things that we talked about, make sure that you check those. Antibiotics, usually the appendix needs to come out, so it's going to be surgical intervention. So you got to do all your pre-op teaching, and they're usually going to go from the ER straight to the OR. Sometimes they'll go in the hospital and have IV antibiotics, but most of the time they're going to go on and go, because you don't want to take a chance on it, that appendix perforating, okay? Because that's fecal material that's in there, and then that goes out, and you've got peritonitis, and then they're going to have more long-term antibiotics, and it sets them up for a systemic, you know, infection. Reducing anxiety. We want to make sure that what population do we normally see appendicitis? Younger kids, you know, we see it with the younger population. So we want to reduce their anxiety as related to, you know, all that's going on with them. IVs, going to surgery, it can be very scary. So we want to talk to that pediatric population, okay? Prevent and treat infection. So I have seen them not take them to surgery and see if it will the inflammation will resolve on its own, but that makes me nervous. Skin integrity, if they go to surgery, you know, they're gonna probably have like the little incisions from the laparoscopic procedure on their belly. Nutrition. Probably gonna have some, you know, general malaise, just not feeling real well, so they may not want to take in PO intake. So we've got to hydrate them, keep them hydrated. If they're vomiting, they're going to lose fluid and electrolytes, so we want to keep them hydrated and keep their nutrition status up. Okay. Patient teaching, they just need to follow up, and you know, all of those things with a post-surgical patient. No lifting, bending, pushing, pulling. Follow up in a couple weeks after surgery, and watch for any signs and symptoms of, you know, further infection. What's next?
Diverticular disease.
All right. Oh, it's on the back. Yay. So diverticular disease, we see that mostly in the sigmoid colon. You can see it throughout the entire colon, but it's mostly going to be in the sigmoid colon. So whenever somebody has diverticular disease, they usually present with varying degrees of constipation and diarrhea. So where was IBS? constipation, diarrhea,
Mhm.
okay? So we can see the same things, bowel irregularities, because what happens is in the colon, there's an outpouching and it's a herniated area in the colon. So things can get hung down in there, food, particles, waste material, and it's in that lower sigmoid area. So things get hung up down in there, and it can cause irregularity, varying from diarrhea. If there's an infection, they can have constipation, and it's because they don't eat a high fiber diet. Most people eat, they don't take in high fiber, and so it causes the increase, the changes in the pressure in the colon. So then we can also see nausea, anorexia, abdominal distension, and bloating. Okay, so all of those signs and symptoms, this can go on for years, all right? The way that we determine if somebody has diverticular disease is how?
Colonoscopy.
Colonoscopy, that's the most definitive way. Now, we can do a virtual colonoscopy, or we can do a CAT scan and see, but the best way is direct visualization, okay? So colonoscopy, then if there's bleeding in the diverticulum, or if there's infection, we can look at the CBC, bless you. We can look at the CBC, check the white count, and those things, but, colonoscopy and then those lab tests are gonna be your biggest way. I mean, even an abdominal x-ray is not gonna give you a whole lot of anything other than if there's a blockage going on. Meds. Let's talk about meds before we talk about nursing interventions. So antibiotics for 7 to 10 days. That's if an infection is going on. So you're gonna be checking for those signs and symptoms of infection. You all know what those are. What, were you gonna ask me something?
Yeah, this is something that you can have and then you have flare-ups. So like the antibiotics is only, like you said, when it's
If
needed.
it's
So
a
I can be
flare-up,
fine, but then
yeah, I
have a
mean, I
flare-up.
could be
Okay.
going along, living just fine and dandy, and then I'll get a flare-up.
Okay.
Because maybe I've, not eaten as well as I should.
Okay.
So the antibiotics are gonna be if there's an infection going on. So they're usually gonna have left lower quadrant pain with diverticular disease. They may have increased white count, temperature, just really just feeling kind of cruddy. You just have pain with defecation, hardened stools, those kinds of things, and you can have mucus in the stools from the infection, from the infectious process, okay? So we can see all of those things but they can prevent, you can have diverticular disease if you eat a high fiber diet and, you keep hydrated and you keep that colon hydrated, then you can not have any problems for a very long time. Never. You may never have problems. Where you get into problems is when you're not doing what you're supposed to be doing and you have a perforated bowel, which is exactly what happened to me. I mean, I had diverticular disease and I had a perforated bowel. That was because I did not do what I was supposed to do, and I was eating nuts, and there's really not a lot of evidence out there that you have to avoid nuts and popcorn and corn. It's whatever aggravates your diverticulars, okay? Whatever aggravates you, you should avoid those things. I still say that nuts, corn, popcorn, those kinds of things, they still, seeds, because they can get in those areas and irritate it, and then for so long, if it sits in there, what happens? You get stuff sitting in there. It can breed and cause infection, okay? So your nursing interventions, if somebody has diverticular disease, our nursing interventions to prevent complications are gonna be increase fluid, increase the bulk. So how would you increase the bulk? With fiber. What are some fiber options? So fiber type cereals, psyllium, which is Metamucil, benefiber, those kinds of things. Slowly introducing that into the diet. Okay, slowly introducing that. And then if somebody has surgery and they have to have a colon resection because of a perforation, They will be NPO before surgery and after surgery, especially if they have an NG2. Usually, if they have a resection, they're gonna be NPO for about 24 hours after, and then start gradually increasing their oral intake. From clear liquids to full liquids, then to a soft diet, and then on to a regular diet. So they'll just slowly progress up. So they want, before a low fiber diet, because you wanna, you just really wanna have some bowel rest. If you've got a perforation, you're probably gonna be NPO. And then you wanna keep a high fiber diet after surgery, because you don't want those diverticulars to come back. You want to change the diet and have it slowly progress up. Daily bulk laxatives, fluids, and then a soft diet, I've already talked about that. And then avoid the triggers, that's definitely. And then you want to exercise, because exercise obviously is going to keep your bowel moving. So we want to incorporate an exercise plan in there. If they start having any complications, we want to report those to the doctor. We want the doctor to know, if there's any complications. But through assessment, I kind of did this backwards, but through assessment, we're going to check their bowel pattern, we're going to check their abdomen, look at what the contour is and all of those things, because the patient's report is going to help you. But if they've got a perforated diverticulum, they're going to present with increased temperature, increased white count, pain, localized pain in that area, and wherever that the material has gone out and probably formed an abscess, okay? And then nausea and pain medications are probably not, if it's a perforated and it's peritonitis, then they're probably not gonna be able to cover the pain medications. It's just severe pain. They'll have to give them a lot of pain medicines. So you'll see that before surgery, okay? So questions about, I know that was kind of fast, but any questions about diverticular disease? Diverticular disease is a lot of teaching, a lot of dietary and lifestyle modifications. Increasing the bulk in your diet, increasing the liquid in your diet, exercising, knowing the signs and symptoms. And if they have an event where they have an infection, getting to the provider, letting the provider know, the diagnostic studies can be done, and then antibiotics. And they possibly will want to do a colonoscopy just to see, how things are going. Questions about that? All right, I know it's time. What do we not cover?
It's on the back of that one, the
Peritonitis, is that the only thing that we didn't cover? Okay.
Okay.
So if if y'all need to leave, you can. I'll cover this real quick. I've already talked a whole lot about it with appendicitis. I know a couple of you got a CANS meeting. I'm supposed to be there too. What? I've got a CANS meeting. I can't go. I'm sorry. I know. I'm sorry. Y'all were the ones that text me. All right. So peritonitis. That is inflammation in the peritoneum. So something has happened that has caused inflammation in that peritoneal cavity. So everything is supposed to be enclosed and closed up. Sorry about that, Kayla. Everything should be closed up, and we shouldn't have anything that is not supposed to be there. So something has happened. We've had a perforation either from appendicitis, the diverticulum, a small bowel, the gastric, the stomach area, something has penetrated, or we've had a penetrating stab wound or, something like that, and the patient has gotten peritonitis for whatever reason. So there's inflammation there. Pain is going to be increased. It can be diffused, so it can go everywhere, or it can be concentrated. The pain can be intense, and the abdomen will be rigid and board-like. So the abdomen can be, I mean, it'll be just as hard as a rock. So when you palpate that abdomen, it's gonna be hard. Patients can get a paralytic ileus, so that means their bowel will completely stop working, all right? Their bowel is paralyzed. So to find out if there's peritonitis going on, we're gonna do labs. So we're gonna get CBCs, we'll get CMPs, we can get a flat and upright abdominal ultrasound. If we think that maybe the gallbladder has perforated, we can do a gallbladder ultrasound because we can get a gallbladder perforation that, you know, causes peritonitis. So they might get a gallbladder ultrasound. CT is usually the way that they're gonna do it. So just remember everything we talked about with CTs, okay? And they may need to do a peritoneal aspiration and get a culture of sensitivity from anything that they aspirate out, all right? But the most definitive way is through lab studies and a CT scan, because that's gonna tell you, hopefully, where the infection is coming from, all right? Meds, we'll put meds with interventions, but they're gonna need pain medications, because this, remember we said up here, intense, excruciating pain. Intense, excruciating pain. And anti-nausea medicine, because you think about it, you've got an infection out here in the peritoneal cavity, it's gonna make you sick at your stomach. And then they're gonna probably need to be on some big gun antibiotics. So like vancomycin, gentamicin, they're probably gonna be on some big time antibiotics if they're not allergic. So you, as the nurse, have to figure out through assessment of allergies if they're allergic to anything. But they're gonna be on some heavy antibiotics, okay? These patients have got to have fast intervention. You have got to intervene. You have got to recognize the signs and symptoms of peritonitis. Subtle signs and symptoms, what did we already say?
Fever.
Fever, increased heart rate, decreased blood pressure with intense localized pain that could spread, okay? Your interventions, fluid resuscitation and replacement of electrolytes. You gotta monitor their eyes and nose, and they may get boluses of fluid. They may be getting IV boluses. So they may give them like a 500 milliliter bolus over an hour, you know, because you want to do fluid resuscitation, okay? They may have to put a drain tube in to drain, you know, they may take them to surgery and do an exploratory laparoscopy and put a drainage tube in, okay? Identify and fix the cause. So if it's a perforated diverticulum, then they're probably gonna, if it walls itself off, and they can and do, then they may need to let that bowel rest and then go back later and do a resection. They may not need to do anything. If it's a perforated gallbladder, a perforated appendix, then they're gonna have to have surgical intervention. So, you know, you're working with the doctor, collaborating on what they need. Let's see, patient teaching and identifying signs and symptoms of shock. So if they get to the place that they've got peritonitis, they're gonna be circling the toilet bowl quick. And you've got to recognize, you've got to be on it. You've got to recognize those signs and symptoms of shock. So peritonitis kind of goes along with some of the other diseases. Take all the antibiotics. Make sure that you're administering antibiotics, when they're ordered, how they're ordered, and they're probably going to be on more than one antibiotic. So it's going to be multiple varying times, okay? I know I covered that really fast, so does anybody have questions? I mean, it's pretty cut and dry. They're circling the drain. These folks are. All right. Anybody have questions about anything that we covered? Okay. If you get home and do, please email me. We need to turn that off. Stop.